Can everyone see that?
Good afternoon, everybody.
Was that the wrong one?
Yeah, I was just on mute, so being off mute definitely helps. As Shannon mentioned, my name is Marie Zephier, and today I will be presenting on quality improvement, working to improve approaches to good health and wellness in Indian country.
I started to share. Was I sharing the wrong screen? Or what?
I'm not sure. I don't see it. But I could just start with an introduction. So as Shannon mentioned, I'm a community engagement advocate for South Dakota, and I work in a project called Partnership to Advance Tribal Health, which is part of the Great Plains Quality Improvement Network. Now, we work with a lot of organizations, so typically this explanation part's a little daunting to follow, so bear with me. So I work as the community engagement advocate in South Dakota, but we actually have my role in North Dakota too, and I work closely with Tasha Health Chair, as well as other project managers and partners throughout the nation. So I'm actually on slide 2.
Can you see that, Marie?
Yes.
Okay.
So can you go to the next slide, please? So the project managers are listed, our program managers, excuse me, here, and we are the Great Plains team that approaches quality improvement in a total of 5 Indian Health Service facilities. And we work with these facilities to relay information to the community. So Tasha and I's role is really to help find innovative and creative ways in how we could increase community engagement through different measures. And I'll go over some of those shortly throughout the presentation. Next slide, please. So the American Indian Alaska Native Healthcare Quality Initiative is actually a national initiative that's funded through the Center for Medicare and Medicaid Services. We subcontract through Quality Innovation Networks to work with the Indian Health Services. And this project was a joint venture between Center for Medicaid Services and the Indian Health Service headquarters. And we started the Quality Improvement and Innovation Group, and we support the work of the Quality Innovation Networks throughout the nation. Next slide, please. As you can see by this map, it shows the different Indian Health Service facilities we work with. We work with inpatient facilities that are in service improvement agreements with CMS. So the Quality Innovation Networks are really working to partner with different organizations and hence the name Partnership to Advance Tribal Health. So some of the facility work we assist with is Joint Commission accreditation readiness. We conduct trainings for leadership development and quality improvement. And our ultimate goals are to increase provider time so they have more time with the patient, increase better access to care, and to improve waiting times for our patients that use IHS services. And those of us who know that these are essential for our communities. Some ways we've done that, we implement customer service training and advocate with the tribes to participate and to work together, facilitate those relationships in community engagement advocacy. By December of 2022, each Indian Health Service facility is expected to implement the patient-centered medical home component of accreditation. And what that means is they have to gear more towards patient, family, and tribal engagement, or PFTE. And so through our community engagement advocacy, we help on different levels. On the project level, we assist with quality improvement in the facilities. So when we do the site visits and the continuous meetings, we help provide recommendations on how they could improve processes and really make them more efficient and effective. On the community level, we do different things to get the tribes to work with IHS, and that looks different in each community. So in one community, we've hosted both IHS and tribal customer service training because it's what they wanted. And since we are driven by what the community wants, that, as I mentioned before, that looks different. In another community, we've done bio cards to increase patients' knowledge about their providers. And so we'll give short bios on where the provider's credentialed, their background and history, and then maybe something they like to do for fun. And we include a picture of them and just really help personalize that process for users of IHS, since historically there's been revolving providers that helps the patient to get to know who they are. Next slide, please. So why quality improvement? We really want to strive for the best quality of care. Our efforts are data-driven, they're patient and family-centered, and it includes the entire team. We strive to solve the problem at the source and continuously do assessments to measure our productivity. And these same quality measures can be used to improve outcomes related to good health and wellness. Next slide, please. So when we're setting our aims for improvement, we really have to think about our SMART goals. Are these aims specific, measurable? Do they define the population of the patients that it will affect? The Institute of Medicine aims for improving the safety, effectiveness, patient-centeredness, timeliness, efficiency, and equitability of the different measures for quality improvement. Next slide, please. So the types of quality improvement that we use in the different facilities are failure modes and effect analysis. There's the Six Sigma process, the Lean process, root cause analysis, and the one that we see most commonly is the Plan, Do, Study, Act. Today I'll be focusing on PDSA, or also known as PDSA, because it's primarily what we use in our South Dakota site. Next slide, please. So let's take a look at how the IHI, or Institute for Healthcare Improvement Science, works alongside with the quality assessment and process improvement process. There's actually 7 steps to IHI's process model, and it aligns directly with PDSA. They're essentially the same. Next slide, please. So as I mentioned, there's steps to this process, and in the planning, there's actually 5 steps where you get started. You assemble your team of people who are going to implement the test of change. You examine the current process, identify your solutions, and then you develop an improvement theory or plan. In the do cycle, this is 1 step. This is where you really test the theory of your improvement. And you ask yourself, what plan are we going to, or what change are we going to implement? In the study cycle, this is another single step where you use the data to study the result. So after a set series of time, we really determine whether or not the change was effective. And in the ACT process, you adopt, adjust, or abort the change. And this is a way of standardizing the improvement or developing a theory that might work better, say it doesn't work. And it's really essential to establishing future plans. Next slide, please. So for the sake of increased understanding, we're going to go through a little PDSA with a hypothetical situation that might occur in the tribal communities that we work in. And as I mentioned, we do these PDSAs in both the IHS and community level. So a tribal community had a recent change in administration. one of the policy changes that the new council implemented was taking away administrative leave for physical activities. After this policy change, the tribal administration noticed a huge decrease in physical activity participation. It also increased the use of sick leave. Next slide, please. So if we were to work through the PDSA cycle in this hypothetical situation, we would first start with the plan phase. So this requires, as mentioned before, to assemble a team and assess the situation and really come up with a plan or a theory for change. So in this situation, a potential plan could be to educate the administration on the benefits of daily physical activity for employees. This includes showing the data and the return on investment. For the do portion of the PDSA, we test the plan. So hypothetically, that could be the team educating the new administration in May of 17 that the tribal council voted to reinstate the admin leave for physical activity. So then comes our study portion. We examine the results and ask ourselves, was this an improvement? So one way to do that would have administrative staff evaluate the number of sick days during a 3-month time period since administrative leave was reinstated. But hypothetically, we noticed that there was a decrease in sick leave. So comes the act portion. And this is really where we ask, do we adopt this change? Do we adjust it to be more realistic? Or do we abort it because it doesn't work? And it's important to mention that not all changes work, and sometimes we have to find different routes or alternative solutions. So in this hypothetical situation, we decide to permanently adopt the policy, and the process of educating the tribal council and reinstating the physical activity policy was found effective. So it becomes an adoption of the policy and a permanent change. Next slide, please. And for the sake of further understanding, we included a second case study involving the tribal health director. So potentially or hypothetically, say the health administrator just starts, and within her first week, she notices that food sales and meetings don't include nutritious foods. And for some of us in tribal communities, there's a lot of people who come in and sell food. It's often their means of making their money. And sometimes in meetings, there's not the healthy option. So after some investigation, the tribal director recognized that there's not access to nutritious foods, and it's difficult and inconvenient for not only staff, but the community members. Next slide, please. So then we define our objective. We really want to increase the access to nutritious foods availability during sales and meetings. So what's our plan? We can hypothetically, we scan existing policies for the healthy meeting and sale options and see if that is something that is available. And then we conduct a small test to change. So say we implement a 2-month time period where we require food sales and meetings to incorporate at least a healthy food option. So not completely eliminating the Indian tacos, but providing something like chips, since they're a lesser calorie option. Or not completely eliminating the staff meal, but making sure that salads and fruits and vegetables are an option during those meals. And then during the study portion, we would assess the data and determine whether or not it's effective. So that would include getting feedback from the staff, whether or not they use the healthy food, etc. And the act stage is where we adopt, adjust, or abort, and really decide whether or not we want to keep that policy. Next slide, please. Another portion of the work that we do is the community clinical linkages. And this is just our what the CDC defines as connecting the community and clinical sectors, which is typically health administration and Indian Health Service. So they work closer together. and help the target population to receive the care that's comprehensive, holistic, and seamlessly integrated with community. It's an additional way to ensure that we're providing best possible care. And there are various key stakeholders that are involved. On the screen, you'll see how these could include people not only from tribal health and IHS, but also from the community. So that could include tribal leadership, such as the tribal council, elders, youth, nonprofits in the community, local businesses. People with shared characteristics are something in common that connects them. And it's really important for us to define our community and our stakeholders in the different initiatives that we're doing. Next slide, please. So some examples of community clinical linkages, and we included these because community clinical linkages is a Center for Disease Control term, but it's a lot of the work that's currently occurring in tribal communities. So, for example, there could be an established good health and wellness committee that helps to implement wellness activities within the reservation or tribal community. Another example would be a patient and family advisory council, or a PFAC, and that is a component of patient-centered medical homes that includes a patient on the council that could help to provide that feedback loop for community members if they want something from the community to go to the IHS or to the tribal org or whatever the case may be. Other examples include community coalitions and steering committees, or tribal health, tribal council, and even IHS collaboratives such as the governing body. Next slide, please. And some of this work we've found some barriers and challenges. For example, stakeholder buy-in. Sometimes we are spread thin in our professions, and what we've noticed, it could be perceived as just another task. It's the broad versus focused agenda, where we could cover so much topics and it's almost sometimes hard to dwindle them down. There is a time constraint. It increases the workload. There's competing priorities. And another one is past conflicts and competition. We've also witnessed silos and like the territorial mentality in different situations. Next slide, please. But there have been a lot of successes. And today I gave you an overview of what that looks like, etc. But we've definitely been successful at unifying efforts for community wellness in some of the respective communities that we work with. There's increases in participation. It increases the number of community programs, as well as the overall improved health outcomes that are associated with bringing these issues to the forefront of our community's mind. Next slide, please. I tend to talk really quick, but we definitely covered a lot of material today, as well as a general overview of some of the work that's done through Partnership to Advance Tribal Health. And if you have any questions, now's your time. So are there any questions?
Thank you, Marie. And again, if you are on a computer that doesn't have a microphone, feel free to type your questions in the chat box. And Jennifer will read them because I can't see them right now.
We did just have one question of if the slides would be available to the attendees, and they will be emailed out. So.
Definitely, and thank you, Shannon and Jennifer, for inviting me and the opportunity, as well as everybody that's on the call at the webinar. I'd like to leave with the thought of us all leaving in action and thinking of one way that we could really help improve the process within our respective projects and programs. Just keep that at the forefront of your mind. And if you have any questions, you could feel free to contact me. On the next slide is my contact information. And Tasha Peltier from North Dakota does the same work that I do, and we work a lot in collaboration. So if you're closer to her or may know her, then feel free to contact her as well.
Thank you so much, Marie.
Yes, thank you, Marie. I'm going to stop sharing here for a minute. I'm going to post the evaluation link in the chat box. If you could take a quick minute and fill that out before exiting the webinar, we really appreciate it. Oops. Or maybe Jen can, it might be easier for you to put it in there, Jen. And lastly, again, if you are new to the webinar, please put your contact information in the chat box so we can send you future webinar invites. If you want, you can just send it to me privately if you don't want to share it to everyone, but the evaluation link is in the chat box. Thank you, Jennifer. It's just a quick evaluation link. And again, this webinar is recorded and will be sent out in an email along with this evaluation link. So if you don't get a chance today, you can do it at a later time. And thank you everyone for joining, and thank you, Marie.
Yeah, thank you. You guys all have a good day.
Thank you. Thank you, Marie.